had to remind the audience, which I'm sure you know, what is the typical management of patients with proctitis. And we start off with a 5-ASA in a topical fashion, to be followed by oral fashion in patients who are refractory, and after that, patients can be treated with topical or oral corticosteroids. And after that, patients should be escalated. But as we've said, this is not done very often, and the guidance on what to escalate them on is not particularly clear. And so, as Noura has mentioned, I've spent the last couple of years writing up the BSG guidelines, the IBD guidelines for my sins, and this is one of the great tables that we've done, and this is specifically for mesalazine, though it's mesalazine for ulcerative colitis rather than specifically proctitis. We've done our own network meta-analysis for induction and maintenance for ulcerative colitis, and we see here the data on mesalazine. This is broad, as I've said, for ulcerative colitis. And we've categorized the magnitude of effects based on trivial, small, medium, and large, as you'd expect in a grade recommendation. And we see here mesalazine has a role in the induction of clinical remission, has a small effect or a small difference, a small magnitude of around 15%. And there's a moderate effect on clinical response when compared to placebo, and there's a large effect when it comes to the maintenance of clinical remission of around 30%. And again, there's a moderate effect when it comes to endoscopic improvement. And the data here is very, very good. Why? There's been many, many studies over the years. So there's a lot of endpoints here to measure. So data is very good. It's very secure. We know that mesalazine has a moderate to large effect when it comes to remission, to response, to endoscopic improvement. But as well, we've tried to move the needle a bit more here, and we do recognize that the evidence on the treatment of proctitis is very, very limited. So we have undertaken a systematic review and a meta-analysis of treatments, of dedicated treatments to isolated proctitis. And lo and behold, many citations here, and around 45 studies that assessed medical therapies for the induction of remission when it comes to proctitis, and only 7 studies looking at the maintenance of remission. But if we go through this, and I'll show you some forest plots here, looking at the effect of 5-ASAs, and you can see clearly top left forest plot, and that's looking at the effect of clinical remission, and we see a clear positive signal there of 5-ASAs at inducing remission, and the bottom left is a forest plot looking at endoscopic remission. Again, a clear signal here, which fits with the signal we see in patients with oral 5-ASAs when it comes for more extensive disease. So these drugs have a key role. They're safe, they're accessible, cheap, but perhaps not in all jurisdictions, as we've just heard. But certainly they have a role, and as well they have a role in the maintenance of clinical remission. And this is the forest plot on the right, looking at the risk ratio of maintenance of clinical remission when it comes to topical 5-ASAs and placebo. So there's a clear positive signal there, and we all know this. And we all know that corticosteroids, again, this is the forest plot for corticosteroids. We know that they are effective in patients with refractory proctitis, and there's a clear signal of efficacy here. But what about which is superior, steroids or topical 5-ASAs? Well, neither. Pretty similar effect here, not showing a big difference. And again, does it make a difference if therapy is used daily or twice daily in proctitis? And no, it makes no difference. So whatever works for the patient, be it oral, be it topical, ideally daily. And yes, 5-ASAs are safer than corticosteroids, but overall, the efficacy is very, very similar. But again, then when it comes to data on tau apurins, data on anti-TNFs, then we start seeing a dearth of data here, not much going around, and approximately a quarter of patients will respond to tau apurins, and these are patients who are refractory to mesalazine. So a quarter of those patients will tend to respond to tau apurins, and if they had to be escalated to anti-TNFs, we see a number of data sets, again, smallish cohort studies of approximately 150 patients, showing some efficacy here, showing a response of ranging between 50 to 80%, a remission of around 70%, low risks of proctectomy, less than 1%, and quite impressive durability when it comes to 1 year and 2 year follow-ups of around 70 to 80%. So Anti-TNFs do work in proctitis, and patients should be escalated to anti-TNFs and thiopurines if needed. And as well, there's some evidence of anti-integrins when it comes to their role in the management of proctitis, again, showing quite good efficacy of around 2/3 of patients being in remission at around 12-month follow-up. So again, these are all therapies which we know are very effective in ulcerative colitis. There's no data specifically in proctitis because they had been excluded in clinical trials, but in cohort studies, we have shown that they've got efficacy. And what about other therapies? And we've heard patients do not particularly like systemic topical therapies, but what about, for instance, tacrolimus? And tacrolimus, this is a study by Ian Lawrence from Australia from a few years ago, and shows quite good efficacy when it comes to clinical response. Again, this is a small study of around 20 patients, 10 patients randomized to tacrolimus, 10 to placebo, showing quite a good signal of clinical response, a very good signal of clinical remission, mucosal healing, any effect of quality of life. So certainly a role for tacrolimus. 2 milligrams BDPR for approximately 4 weeks has a quite a good role in the management of refractory proctitis, especially in patients, if patients do not want to go on systemic therapy, on oral therapy, or more systemic advanced therapies. And again, this is other data from organic arsenic, acetarzole. This is a study from Cambridge, which is and this is around 30, 40 patients with Crohn's disease and ulcerative proctitis, quite a refractory population, which have been exposed to thiopurines, methotrexate, anti-TNF agents. And again, here we show good endoscopic response in patients with organic arsenic pre and post-treatment. This is again topical therapy for 4 to 6 weeks, which shows quite good efficacy. And again, this is a similar study that we've done in Nottingham using organic arsenic. Again, topical therapy, and there's a good 50% remission rate, and around 2/3 of patients will respond. And these are patients that are refractory to 5-ASAs, refractory to thiopurines. And is there any systemic absorption in the arsenic? Not really. As you achieve mucosal healing, systemic absorption decreases by approximately a month to nil. So possibly some role here, but this is off-license therapy. So what about, to conclude here? Well, isolated proctitis has a significant effect on quality of life, and I think this is underserved. Patients tend not to be escalated just because they have only proctitis, and there seems to be a reluctance to sometimes escalate these patients just because of their disease location. Really, they're overall under researched. And as we've said, patients and clinicians do agree that we should be escalating these patients to more advanced treatments like any other more extensive colitis. We need more research on what PRO should be using in these patients. Stool frequency is obviously not a good one in patients with proctitis. As we know, constipation seems to be quite an important symptom in these patients. And again, we need to generally have a bigger drive to recruit these patients to clinical trials, because till now, this hasn't been the case. And I think that takes me to the end of my slide deck.